Yes, and we're using certain elements of that, from behavioral health to mostly inpatient, but we use the broad bandwidth from outpatient, SNFs, rehabilitation elements to the acute inpatient side, and then behavioral health in other areas as well. We dialogue with the payers and identify, even in their own systems, where maybe a claim was rejected and it was just a simple technical error that needed to be addressed. Once we agree upon it, we then push it through the system again and then make sure that that bill is paid and that particular claim can be closed on both sides of the fence and the patient doesn't even see it. Other times we see letters going out to the families, the patient. When I say families, because there may have been a bad outcome and the family received a letter from the insurance company, the payer side, or whoever administered the claim, and then the hospital would receive a copy of that letter stating that, oh, maybe the care they didn't feel was medically necessary, the length of stay was too long, the level of care wasn't appropriate. We, at that point, will take on that particular situation, review it with our clinical staff, use MCG to support our defense of why that patient needed to be at that in that clinical setting or why that patient needed to be admitted, or in some cases, for the payer side, educate the provider side that, you know, this patient really did not meet inpatient criteria. This is why. This is evidence-based research out there that supports it. Not just the research, but a panel of experts and colleagues and a whole bandwidth of individuals who have experiences in this area that said this patient probably would have been better served in the administration of their healthcare policy or plan if you would have managed it in this direction. And so we provided that educational component as well. We may have actual dialogue with them. We'll sit in a conference call with, let's say, the president of Humana and, the medical director for Humana, and we'll dialogue. Hey, this is what we're seeing. This is what some of our accounts are seeing. We're using MCG. This is our interpretation based on the evidence or the notes and direction or guidelines that MCG provides. We understand you administered this claim as such. Please explain that to us so we can better understand your thinking. And then we'd like to give you some feedback on what we thought on this particular claim. So it opens up a whole opportunity for dialogue. And at this point in the claims that we manage with Humana, there's a significantly better communication, a dialogue going on in terms of the handling of claims. And I do believe they've learned from us as well as we've learned from them. I clearly understand the medical director's view and approach on handling claims, particularly in the OBS environment. And when I see that, I understand how it's going to be addressed based on that practitioner's approach. I also have my MCG tools or the decision platform that we're using for that particular claim based on their contract. And then I'll address it using that tool. If I can't support it, I'm going to support Humana. If I can support it, I may come back and say, Doctor, I understand your approach is going to be as such, but here's some information that may help you or might change your mind. Can we discuss it? And we open up a channel of dialogue. The end result is the patient benefits, and they want that member from the payer side to benefit. And the provider wants to make sure they're getting paid and they don't have to outsource it or sell that debt to a third-party collection. Even though they can't bill that patient directly, they can still sell the debt. And then they've impacted their community and the impression of that organization in the community. So if we can stopgap that, it's a win-win for everybody. We just help create and help the parties resolve what that element of contention is. We use MCG to do that.